Hey, it's Dr. Silva, and I want to talk about diagnostic labels. Patients often are eager to know what it is that they're suffering from, and they want me to name it, and they want me to classify it and categorize it. But I want to talk a little bit about what the implications are and how we use it clinically. And I just want to start by saying that it doesn't matter what we call it. Right? I'm going to treat target symptoms. When a patient comes to me for the first time, I'm going to identify the target symptoms, and I correlate that with the mental status exam and the history. I want to make sure that I'm getting accurate information, that the patient's being reliable. But assuming all of that, assuming that I'm getting good data, we identify the target symptoms and then we treat those. We decide whether we need medication, almost always yes, when the patient comes to see me, and we decide what neurotransmitters we need to manipulate, either up or down, and what side effects we need to avoid, which ones are deal breakers and which ones would be poorly tolerated because of the demographics. Elderly people tolerate certain side effects a lot less than younger people, such as constipation or urinary retention or blurred vision, things they might already be experiencing, memory loss. So those are all the factors that go into identifying what to treat and then choosing how to treat it, and then understanding what comorbidities there are, what other diagnoses, both psychiatric and non-psychiatric, that we can't exacerbate, that we can't make worse because now we're increasing dopamine over here or increasing serotonin over there. And also drug-drug interactions, looking at what other medications they may be taking. I mean, there's so many variables, lifestyle variables, so many things. And then whether or not we need psychological treatments, whether we need to treat something other than with a prescription pad. But that's how we start, and that's the best start, and that's always, you can't go wrong that way. I teach my residents and my medical students that that's the way you should proceed. The first thing you should do is determine whether the person needs medication, whether there's actually something chemically wrong, biologically, endogenously wrong with the central nervous system that we have to fix with medicine, or whether the person is merely experiencing a tough time. And we approach it different ways, but a lot of times patients want me to name what they're experiencing, and I do put a name to it. I always, we have to have a diagnostic paradigm under which to operate, but that's what it is. It's a paradigm, because in psychiatry, everything is syndromal. Everything is a syndrome. Major depressive disorder, for example, it's not one illness. It's not just one illness. Two patients that both meet criteria for major depressive disorder don't necessarily have the same condition. They don't necessarily have the same etiology, the same cause, and they don't necessarily have the same pathophysiology, the same disease process. They may not even have many of the same symptoms because there are criteria. And if you have enough criteria, then you qualify for a diagnosis, but that diagnosis doesn't mean the same thing as a diagnosis of type 1 diabetes mellitus. That's a very specific diagnosis with a very specific pathophysiology in it, and it's the same in everybody. And it's the same thing with stage 3 colon cancer. It may have started for different reasons, combination of genetics and lifestyle, but it is what it is, and stage 3 is stage 3 in everybody, and so it's uniform. But in psychiatry, if I say you have generalized anxiety disorder, I'm not saying much. I'm not telling you, other than genetics, it's always a genetic condition, other than you inherited it from either your mom or your dad, one of the two of them. It never skips a generation. Beyond that, I'm not telling you much. I'm not telling you really why you have the symptoms that you have and why you don't have certain other symptoms, why you've never had a panic attack, for example, but you have OCD, why you don't have any social anxiety, but you have a lot of intrusive, morbid thoughts. And I can't tell you why it started when it did in you, why it's as bad as it is. We just don't understand it well enough. And so diagnosing you is usually to say, well, we have this constellation of symptoms. We have all these symptoms, and that meets criteria for this syndrome. But I don't necessarily know what's causing it. I may have a general idea, your genes, but I may really not know much beyond that, what's causing it or what's really going wrong. Is it a problem? Where's the problem? Is the problem with a certain region of the brain or a certain area of the central nervous system? Is it with this neurotransmitter or that neurotransmitter? Is it that there's enough neurotransmitter but the neurons don't know what to do with it? I mean, it's something that we may never know. It's certainly where we are right now in psychiatry. But we treat the symptoms and we do make a diagnosis. But the diagnosis is mostly significant for the prognosis. What the diagnosis does, and it is a paradigm because it's a syndrome and it's not necessarily the same in every patient. And so it's just a paradigm that we're going to assume, for example, if this is recurrent major depression, we're going to assume that it is recurrent. It is going to recur. Eventually, if you live long enough, you will have another episode. It is episodic. We expect it to come back. We expect a relapse. It's like certain forms of cancer. We might treat you with chemo and you might get all better and there might be no evidence of the cancer, but we expect it to come back because of the type of cancer it was and because of the stage it was when we treated it and because of statistics, because of the epidemiology, because people that have that type of cancer in that stage that get treated, this percentage of them have a 5-year survival and this percentage of them end up having a relapse. And so in psychiatry, when we make a diagnosis, it gives us prognostic information. The difference between an adjustment disorder with depressed mood and recurrent major depression is that one is a response to stressors, and when that situation resolves, then you're going to get better, and we don't expect that to ever come back. You might have another crisis, another tragedy down the line, but it's not going to be the same as this episode. Also, there are differences in terms of how many neurovegetative symptoms you typically see. You see a whole lot more physical symptoms with endogenous illness like recurrent major depression than you would with an adjustment disorder, the severity and the need for medication, etc., etc. So the paradigm is important and it does have predictive value. But we can't really predict it with 100% certainty. The prognosis is not ever 100% clear. There's so many variables that impinge upon the treatment itself, like compliance and lifestyle variables and drugs and alcohol and coping skills and et cetera, et cetera, et cetera. Expectations, attitudes, perceptions, so much that goes into it. So if we're treating target symptoms, and the diagnosis is only a diagnosis of a syndrome that mostly is going to help the clinician anticipate what the treatment course is going to be and is not really going to impinge that much on the acute episode because we're going to treat the target symptoms and we're going to treat the target symptoms. It's not really going to change our management in the short term because all that about eliminating the symptoms and avoiding certain side effects and avoiding toxicity and not impinging upon the lifestyle and educating the patient and all of those things that we have to do, and educating the family and involving the family and achieving sobriety, and all of those pieces are going to be the same regardless of whether we're dealing with an adjustment disorder with depression and anxiety or whether we're dealing with recurrent endogenous major depression with anxious distress. The names are different, and they are different paradigms, and they are different conditions, but it's a grab bag of conditions. It's plural on both sides, especially when you look across populations of patients. It's important not to get bogged down in the nomenclature. The nomenclature changes every few years anyway as we refine our understanding of certain conditions and we decide. There are committees that decide each time the DSM, the Diagnostic and Statistical Manual of Mental Disorders, each time a new edition is put out about every 10 years, there is a committee. It's an administrative process of deciding, you know what, we're not going to call this anymore. It doesn't change what the underlying conditions are. It's just our classification. And maybe these labels, these names are misleading. And maybe this is a better name. Like, for example, with alcohol use disorder and the substance use disorders. That's the current terminology. Use disorder. As opposed to abuse versus dependency. Because there are colloquial uses of drug abuse and drug dependency that don't necessarily mesh with the clinical. And then also you could be dependent upon a drug but not physically dependent, so tolerance and withdrawal aren't necessary to diagnose in the old system to diagnose chemical dependency, and so there was this ambiguity and this confusion, and so now we've taken that away by cleaning up what we call it. And also sometimes we discover that what we thought was one syndrome is really two separate syndromes, like when you identify a new species so that's all nosology. That's all the science of classifying, and it reflects more our understanding of the diseases that present. It tells us more about that than it does about what to do and why human beings are afflicted by these conditions. And then the Diagnostic and Statistical Manual, the Bible of psychiatry. It's not the Bible. There is no Bible of psychiatry. The Diagnostic and Statistical Manual, although clinicians do use it to justify their diagnoses, and insurance companies point to it before they'll pay for certain things, and medical students and residents and fellows are taught to refer to it so that they can have a better understanding of these syndromes. I'm not going to not diagnose major depression because I couldn't get 5 out of 9 of the things on this list, and the book says that you need 5 out of 9 before you can call it major depression. Clinical diagnoses in the real world are made based on your experience, based on the presentation, your intuition. It's obvious to me when a person presents to me with clinical depression that's endogenous recurrent major depression. It's obvious by their history, their personal history, their family history, their presentation, their mental status. I don't need to go look in a book when I see extreme psychomotor retardation and negativity and anhedonia and low energy and hypersomnolence and a weight change. I don't need to count it up and go check the book. Really, the book is a research tool. Because psychiatry is so nebulous, and because we can't take a biopsy or a drug test and send it out and confirm the diagnosis that way, and because clinicians are prone perhaps to misinterpret, or if we're just looking at it and using our gut, which is what I just said, ironically in the real world, what an experienced clinician does most of the time. But when you're looking at more than one clinician, each one is maybe going to approach it differently, and they're maybe not going to agree on the diagnosis. And that happens in the real world. And one of them is not necessarily wrong, because that's the point I'm trying to make with this whole video, because it's a paradigm, and what you call it is not as important as what it is and what the symptoms consist of and how you're going to treat it. So you could have two clinicians that would call, I'm going to call it this and I'm going to call it this, but we're going to treat it with the same types of medications and they're going to get better. And so who was wrong? Not necessarily either one. But when you're doing research to determine whether a medication helps a certain condition, then it's important that the population that you're studying be uniform. It's important that the people that you're studying actually do have bipolar disorder. And so in order to decrease the likelihood that you are actually studying a disparate sample of people, there's this tool, this research tool that says, okay, well, if they have 4 out of 5 of these, and if they meet the time criteria that they've had the symptoms for at least 2 weeks, and it's not due to this, and it's not due to that, and blah, 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 and we follow the cookbook, then we can say with reasonable certainty, not 100%, but with reasonable certainty that, yeah, it is in fact major depression that this particular individual has, and so they qualify for the study, and now we can run the study and test the medicine and see what happens. And even then, studies are fraught with all kinds of problems due to subjectivity, because then you also have to measure their improvement, which can also be subjective. Again, you operationalize those definitions and you quantify as much as possible and you try to objectify as much as possible, take the subjective element out of it. And then you have the double-blind, placebo-controlled model. And so you end up with some pretty good data that you can use. That's what that book is for. That's why it was developed. That's its most appropriate use. Not as a day-to-day clinical handbook to tell you what that patient has. If you can't look at that patient and talk to that patient and find out about that patient's family and find out what's going on and arrive at a diagnosis or a diagnostic paradigm, then you're not competent yet as a clinician. generalized anxiety disorder, just to give you an example. I realized fairly recently, a few years ago, that the individual who comes to me with panic attacks, who is having spontaneous panic attacks that wake him up from sleep, and who has always been an anxious person, of course, right? Because most of us, even when we're overwhelmed, don't have actual frank panic attacks. Those that do are anxious types. They were nervous kids. They maybe have, it's like that Venn diagram. So maybe they're clinically shy. Their shyness, their social anxiety is clinically relevant. Or maybe they have a touch of OCD. Or maybe they had OCD when they were a child and they grew out of it, which is very common. Or etc. They have generalized anxiety disorder. Yes, of course they do. You can't be having panic attacks. I'm talking about spontaneous panic attacks where you meet the frequency of them. You're having them a lot and in response to stress. I've yet to meet a patient who meets criteria for panic disorder who isn't just the person who had one panic attack or who had a few panic attacks. Lots of people have had panic attacks that don't have panic disorder. But if you have panic disorder, that condition, 100% of them have generalized anxiety disorder. They all do. Not all patients with generalized anxiety have panic disorder or even experience panic. And you could have a patient with generalized anxiety disorder who's never had a panic attack and somebody who's had more than one panic attack who doesn't have generalized anxiety disorder. That all of those permutations are possible. But what I realized is that panic disorder is not a separate thing. It is just very severe generalized anxiety disorder. Now that's according to me. According to the DSM, according to the American Psychiatric Association, they're two separate syndromes. They're not two separate syndromes. In every case that I've treated of panic disorder, and I'm talking about that hardcore panic disorder, all of them are worriers. They catastrophize. They tend to think about the worst case scenario. They dwell. They have all of the characteristics of a person who doesn't have enough serotonin or doesn't know what to do with the serotonin that they have. They need serotonergic pharmacotherapy. They need augmentation. They get a whole lot better. It's a life changer when they start the appropriate medication. They don't just get a little bit calmer. Their mind stops spinning and they stop having these dizzying, intrusive, morbid thoughts, the overthinking and the obsessions and the compulsions and the just whatever flavor they have. It all gets so much better. And so my point there is, should I call it panic disorder? Should I automatically diagnose generalized anxiety? Should I diagnose both? It doesn't matter. It doesn't matter what I call it. And the fact that the American Psychiatric Association that publishes the DSM, the fact that they call people who are having a lot of panic attacks all the time one disorder, one syndrome, and they call people with generalized anxiety another syndrome, when, as though to say they're two separate things. What about if I did diagnose both of them in one individual? Am I saying they're two separate things? They're two separate conditions with two separate etiologies and two separate pathophysiologies? No. No. Whatever the etiology of this is, it's genetic. The pathophysiology is what it is. It's inscrutable. We don't necessarily know what it is. We haven't figured it out. And it's maybe different in different people with the same syndrome. Whatever's going on, the same thing that's giving them panic attacks all the time is the same thing that makes them chronic worriers and overthinkers and etc. And so all of this is nosology. It is the classification of disease and what the terms we use and how we approach it and the paradigms that we use to better understand as much as we can understand it, knowing that it's not as precise as it is in internal medicine or as it is in even neurology. Because we're dealing with the mind. We're dealing with thoughts and emotions and behaviors, and those things are sometimes very, very difficult to analyze. But treating is more empirical. I do have another video on empiricism. Diagnosis is important, but the approach should be Let's agree on target symptoms. Let's make sure we're using the same terminology. Semantics is critical. Patients should be discouraged from using medicalese. Clinicians should make patients elaborate when they give medicalese, when they use terms like panic attack or mania or racing thoughts. I have another video on that as well. They should really be concrete when they're talking about their symptoms. And don't worry about the label. It's not going to make a difference. Anyway, that's all I wanted to say about putting a name to what patients are experiencing.